And welcome to the Dr. Bob Show. In the last 2 to 3 years, I've had two very good friends die of ovarian cancer. How common is ovarian cancer? Are there symptoms that will help us diagnose? Is there a way that we can prevent? Who is at risk for getting ovarian cancer? We'll be answering those questions on this show. My guest is Dr. Brook Saunders. Dr. Saunders is a board-certified gynecological oncologist, deals with gynecology cancers and their treatment. He'll be answering our questions on this very, very important illness. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about migraine headaches. There are some new medications to help prevent migraine headaches from occurring. It's life-changing, life-altering to some people that have frequent migraine headaches. And we'll be talking about gallbladder disease. What are the symptoms of gallbladder disease? How do you know if you've got it? And what can you do to get those symptoms better? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Brook Saunders, board-certified gynecological oncologist, and we're talking about ovarian cancer and what we can do about that illness. Brook, welcome to the Dr. Bob Show.
Thank you. Thanks for having me today.
Tell me about the ovaries. Where are they located?
Well, the ovaries, a lot of people know about getting pregnant. All the ladies do. They're on the side of the uterus, down deep in the pelvis. You have one on each side. They're what release the eggs every month for a woman to try to get pregnant when she's still having her periods. And
so do they usually cause problems? We'll be talking about ovarian cancer, but the ovaries, are they usually problem-free, or do they sometimes get cysts and cause pain?
Very frequently, women will develop cysts on the ovaries. A woman makes a cyst every month when she's ovulating to try to maintain a pregnancy, and usually that cyst goes away and doesn't cause her any problems, but sometimes they do turn abnormal and turn into cancer.
So if somebody has ovarian cancer, are there a group of symptoms that these people seem to have? Is there an age group that they fall in? Is there some way we need to be more cautious in preventing? So let's talk about symptoms.
Symptoms, unfortunately, are pretty nondescript. A lot of ladies will have these and not know that there's anything really even wrong with them. They may feel that their clothes are fitting tighter. They have some what we call abdominal bloating or distension. They just feel like they can't eat as much food as they did, or they have issues with constipation or with their bladder being a little overactive sometimes.
So they just sort of feel full.
Correct.
Is that because the pelvis, the cancer is large and it fills up the pelvis, or there's fluid there, or we don't know why?
It could be both. Sometimes they have a mass on the ovary that gets big that does make them feel full. Other times the cancer could have caused their body to make fluid that fills up their abdomen and actually makes some women feel like they're pregnant.
Do women know something's wrong when you say distension, my clothes don't fit as well, that I've got a change in urinary tract habits, urgency?
Right.
Do they know something's going on?
A lot of times they do, but women are just so busy they just don't really understand that there is anything going on. And the biggest thing that we tell ladies is just try to pay attention to your body. If there's a symptom that does occur and it doesn't go away, you need to have it checked out, because those are the ones that we do need to look into.
So who is sort of predisposed? What are the risk factors that somebody has to get ovarian cancer?
Well, fortunately, ovarian cancer is pretty rare. Usually about 1 in 70 women will get it. If you have a family history, you may develop it. Your risk is a little bit higher than the average woman, but it's still only about 1.5% to 2%.
More common the older you get?
It is. As you get to be 50 years old, it does increase, and as you get to be 60, it goes up even higher, and 70 even higher. There are some genetic mutations that can make that risk go up even more, but it's usually about 1.5% to 2%.
So genetic mutations, is this the breast cancer one, BRCA1, BRCA2?
Right. This was the BRCA gene. There's a BRCA1 and 2, and those increase your risk to where if you have a significant family history of having cancer, we do check some of those ladies out. And if they have one of those genes, their risk can go up to anywhere from about 20 to 40%.
Wow. So if somebody has breast cancer and they do genetic testing and they've got these abnormal genes,
Correct.
then you pay more attention to the ovaries?
If they have the gene that's abnormal, we actually will take the ovaries out at a certain point in their lives to try to prevent them from getting cancer.
So are the ovaries sort of a cancer catcher? You know, sometimes I look for people trying to make a decision whether to take the uterus out or not, and I say, well, you know, it's after a certain period of time, it doesn't provide the function it was meant to.
The ovaries aren't really a cancer catcher. We do think now that the fallopian tubes can cause some of these ovarian cancers. So now we actually are recommending that ladies, if they're having surgery in their pelvis, have their tubes taken out if it's for anything that appears to be benign.
So if I was a lady, there was a family history, my genetic testing wasn't done, and I get vague symptoms of increased abdominal girth. My clothes just don't fit as good. They feel tighter. I'm eating food, but I get full easily, and I've got frequent urinary tract irritation, so I go to the bathroom frequently. What would you do to help diagnose? What kind of testing do you do to help diagnose the ovaries and see if they're normal or abnormal?
In that situation, I'd recommend they go see their family doctor or their OBGYN. Tell them of their symptoms. If these symptoms persist, they do need to have them checked out. Most of the time they'll have a pelvic examination at the office.
Can you feel the ovaries well on an exam?
Sometimes you can. Sometimes it's a little difficult on each individual patient. If we can't feel the ovaries, or if you're not sure on the exam, that's when we usually recommend getting an ultrasound to look at the ovaries. Or if there's a significant abnormality, then we might get something like a CT scan to look at the rest of the abdomen and the ovaries.
So if you get an ultrasound, is that an abdominal ultrasound where you run the ultrasound over the belly, or is it transvaginal?
Sometimes it's usually a combination of both. Most of the time the ladies will get an abdominal and a vaginal ultrasound because it gives you a better picture of the ovaries when you're looking at it.
Usually, how close is the ovary to the vaginal vault?
It's just a few inches away.
So it would be much closer than if you ran it over the belly. We get really good definition of pictures when we do ultrasounds. Is the transvaginal, is that a good picture taker for ultrasounds?
It's the best option we really have for viewing the ovaries.
So what does a cancer look like? If you do a transvaginal ultrasound, what does it look like? Can you see irregular borders? It's got a different size?
They may be enlarged. That's one of the things you look at. You also look to see if they have solid areas inside the ovary, or if there's fluid around the ovary, or there's other characteristics that they almost look like they have a little mushroom stalk inside the ovary called a papillary excrescence. That's another thing we look at. And if you have those, you're at a higher risk for that ovary being abnormal.
So if somebody has a positive, let's call it, it looks like something's abnormal there in the ovaries, is that a sign that you're going to do what?
At that point, if it is an abnormality, most of the family physicians or the OBGYN doctors will order some blood work, and usually they get a CA-125 test.
CA-125.
CA-125. That's a blood marker that can be elevated in most women who have ovarian cancer. About 80% of the women with the most common type of ovarian cancer have that to be elevated.
Is it a sign, the CA-125, of activity in the ovary?
It's not really a sign of the activity, it's just that there's an abnormality that puts it at a higher risk for being malignant.
So if somebody has a abnormal ultrasound and an elevated CA-125, it makes the suspicion much, much, much higher. Then how do you find out?
At that point, a lot of the times the family physician or their OBGYN will refer them to somebody like me, and then we may get a CAT scan to look and see what's there, but usually we have to perform some sort of surgery to look inside the abdomen to see if the ovary does have abnormal cells on it.
So you can look into the abdomen. What do you call that procedure?
Laparoscopy.
Laparoscopy. And so you can visualize the area of the ovary and see what it looks like to the human eye there.
Correct. And you can either take out the ovary then, or you can do biopsies of other areas inside the abdomen to see if they show that there's cancer cells there.
So when you do the laparoscopy and you take a little biopsy and it comes back abnormal, is there treatment?
There is.
And that's what we're going to be talking about. Yes, we can find it. It's there, and there is treatment. It's two avenues, and we're going to look and see what's best for different patients to help them get better and have the best life they possibly can. We're talking with Dr. Brook Saunders, board-certified gynecological oncologist. We're talking about ovarian cancer. The symptoms when somebody gets ovarian cancer are sometimes very subtle. It may be increased abdominal girth. My clothes just don't fit properly. I have early satiety. When I eat food, I get full. I can't eat a good meal. There's changes in urinary tract irritation habits, going to the bathroom more frequently. Very vague symptoms, usually not necessarily weight loss, but just these vague symptoms, and probably recognizing something's different, something's wrong. Now, we talked about doing the laparoscopy where you look in, and when you look into the abdomen and you locate the ovary, what's a normal ovary look like?
The normal ovary is about the size of a walnut, and it looks white in nature typically and has a normal smooth texture to the outside and to the fallopian tube right next to it.
So when you're looking at that area, that's a nice thing to see, a nice smooth white walnut that's there. So what would a cancer of the ovary look like when you're looking?
They're enlarged. They could be something even like an orange or a grapefruit, or even bigger. They don't have smooth borders. They might have solid areas on them. They might have tissues that just look really abnormal and almost necrotic.
You get a biopsy right there and have the pathologist do a frozen section?
You either take a biopsy of some tissue around the ovary, or you take the ovary out if you can. You try to take it out intact so that you don't spill any of the ovary if there is a cyst, and then you usually let the pathologist look at it to tell you what is wrong with it.
Do you look around the rest of the abdomen to see if it's already spread or what else is in there?
All right, we do look at the upper abdomen, we look at the diaphragm, we look at the liver, the stomach, the spleen, and look throughout the bowel to see if there are little nodules of cancer growth in some of those tissues.
What do they look like if you're looking there and it has spread?
I usually tell patients that it looks like somebody has taken little BBs or Rice Krispies and just kind of thrown them into their abdomen, and they just stick in different areas, and that usually looks like the spread cancer.
So to me, that would be very disheartening to look in and see a lot of BBs or a lot of Rice Krispies that were there, meaning that it had spread, was growing several different areas. If that occurs, what are our treatment options for this patient?
It depends on how extensive it does look. In certain situations, we will go ahead and proceed with a bigger surgery at that time, where we do a complete hysterectomy and take out the tubes and ovaries, and we try to take out all the cells that look like they have cancer on them.
How do you take them out? If somebody had a lot of BBs all over parts of the GI tract, how do you remove that? Do you pinch it off? Do you burn it? What do you do?
We can either sometimes cut it out at the time of surgery. We make a bigger incision and remove them that way, or we will use a laser sometimes or some other devices to kind of burn them in surgery.
So you've got a name for that, cutting down the number of tumors,
right,
removing them. What do you call that?
That's called a debulking surgery.
Debulking. So what you're doing is you're taking out as much as you can find. To me, that would take a long time.
It can. Sometimes it'll take you anywhere 3, 4, 5, 6 hours to do it.
Wow. That would be very tiring, very difficult, very pressure-filled, I would think, looking for all those spots. Is there a direct correlation with taking out more of those BBs versus leaving some behind?
You try to take out as much as you can to where you can either get rid of all of them, or you take it down to where they have less than about a centimeter of them left. So a small little area inside the abdomen.
So then when you come out, when you remove the surgical instruments, you've debulked as good as you can, then what do you do for the patient?
Usually we give chemotherapy at that point, once they've healed up from their surgery.
So chemotherapy is cancer medications to help kill the remaining tumor?
Correct. We're trying to get the areas that were so small that we couldn't remove them, but they're still there.
And so if you do chemotherapy, how difficult, how hard is that on the patient? Is there a standard form?
There is a standard regimen that we use for ovarian cancer, and it's pretty much out of a cookbook almost. The majority of women in the country get a standard chemotherapy regimen with 2 drugs called carboplatin and Taxol that we usually give them about every 3 weeks apart once they finish with their surgery and they're healing from that.
So you give every 3 weeks, you give a treatment. How many of those 3 weeks do you start with?
Usually they get 6 rounds of chemotherapy, or it's called a cycle, so 6 cycles of chemotherapy.
During that period of time, how are you knowing, or what do you have that says this appears to be working or it doesn't appear to be working?
A lot of the time it's just the symptoms the patient's having. We really just monitor them now to see if they're feeling less bloated, less distended, to make sure that the fluid that they had, the ascites, before the surgery isn't recurring.
What's happening to the CA-125?
It usually goes down during the chemotherapy treatments. If it starts out really elevated, we can monitor it during their treatments and then see if it is coming down.
Do you get a routine CA-125, the blood test, routinely after chemotherapy to maybe wonder if it's coming back?
We used to all the time. Some of the newer studies that are out there don't show a lot of benefit in that. It just shows that it increases a patient's anxiety more than anything else because they're worried about their CA-125 number. But usually now a lot of people have gotten away from monitoring that. So I sometimes do, but oftentimes I don't.
Do you ever go in and debulk, take out as much of the little cancer as you can, then give chemotherapy, and then go back in and try and remove anything that's left over? Do you ever go back in a second time?
Usually if we're going to have to go back and take something out, we usually give chemotherapy up front to shrink things down instead of debulking them up front, and then we go back and take the cancer out in the middle of the chemotherapy. Sometimes you might go back and take stuff out later on, but it's not as common.
When you find ovarian cancer and you find it where it's spread in the abdomen and you're treating it with chemotherapy and you've done debulking, can you tell who's going to do well and who's not going to do well? Are there anything that you could look at the patient or anything you're looking for and saying, no, I'm afraid this person's not going to do well, or I've got every hope in the world this patient's going to live a lot longer?
Usually we have every hope that they're going to live a lot longer. There are certain patients who unfortunately don't respond to chemotherapy, but usually we don't know that up front. There are some things, the BRCA gene we talked about earlier, those patients tend to do a little better with chemotherapy, but oftentimes we don't really know who's going to do well or not until they've had some chemotherapy.
You know, it must be wonderful to be able to take care of a patient that has a bad disease, ovarian cancer that's spread, to be able to guide their treatment so that they can be more functional and can live a longer and better life. I thank you for that.
Thank you very much.
You've been a great teacher. Thanks for coming to the Dr. Bob Show. I hope you'll be able to come back again.
I'd love to. Thanks for having me.
Great information on ovarian cancer. A lot can be done. You need to pay attention to these very subtle symptoms. You need to know if you're at a high risk, and therefore your examinations would be more frequent, or you'd pay more attention. If you do find it, know there's hope, know that there's treatment that can help you. And now you're going to want to stay tuned. We're going to be talking about migraine headaches. There are some new medications out now that help prevent the frequency of migraine headaches. We'll be talking about those and how they work, and symptoms of gallbladder disease. A lot of times we wonder if a patient has gallbladder disease. How do we really know? A lot of information for you. You'll want to stay tuned. I want to thank Dr. Brook Saunders' wonderful discussion on ovarian cancer, vague symptoms, treatment is available. And now questions for you, the viewer, that I think will be important to your health. Dr. Bob, what is the newest treatment for migraine headaches? Well, let's talk about migraine headaches first. Migraine headaches are devastating. They're usually on one side. They're vascular headaches, so they're usually throbbing and pounding headaches. Usually light bothers somebody, usually loud noises bother somebody. The migraine headache, if untreated, can last up to 72 hours. Usually it hurts so much that somebody goes into a dark room, makes it very, very quiet, and they'll try and go to sleep. Now, if somebody's having a migraine headache, if they recognize it early, sometimes taking simple medicines such as Tylenol, such as ibuprofen, will help relieve that headache right there. And then there are some newer medicines out, triptan agonists we call them. So it would be Imitrex, Maxalt, Zomig. These are medications that you can take during the headache, during the migraine, to get the migraine to go away. We're going to be talking in just a minute about a even newer medicine to keep the frequency of developing migraine headaches less. Now, what can we do to prevent migraine headaches? Well, number one, we need to keep a diary of when we seem to get the headaches. It's when we're sleepy, when we've got stress, when we're not eating properly. All of these things can bring on migraine headaches. So loss of sleep, bingo, you may get pain. Something that causes pain can trigger a migraine headache on top of that. So we need to recognize what it is. Then there are medications like beta blockers, blood pressure medications, that if you take a beta blocker, it may prevent you from getting migraine headaches. There are calcium channel blockers. There are other medications that we can use to decrease the frequency of migraine headaches. Now, there's a new medicine called, a new group called CGRP, and it's calcitonin gene-related peptide. So if we take a migraine headache and we study the brain during that period of time, there's a peptide, there's a protein that floats over the brain that seems to transmit pain, that vascular throbbing pain. If we can block that, and that's what these new medicines do, then we can keep the frequency of migraine headaches from occurring. There are some people that actually get migraine headaches 20, 25 times a month. That would be devastating. So it cuts down the frequency to maybe 5 days a month, and that would be a blessing to those people. So know that there are medicines to help prevent migraine headaches. Question number 2. Dr. Bob, what are the symptoms of a gallbladder attack? Well, the gallbladder is right under the right side of the abdomen. It's under the liver. It conserves bile, and the bile is excreted into the small bowel to help break down fat. And so the gallbladder is a very important organ that we have. We can take out the gallbladder and the patient does really quite well. So the symptoms of gallbladder disease are if the gallbladder becomes inflamed. Since it's on the right side, usually there's pain on the right side. It can actually radiate up into the right shoulder. You don't feel anything wrong in the shoulder, but you've got pain up in that shoulder. The pain from the gallbladder can go straight through to the back. And so you've got a pain in the back, a pain under the belly. If you eat fatty foods, the gallbladder tries to squeeze down and push the gallbladder bile down to help digest the fat. So a fatty meal will cause the gallbladder to contract, and if it's a diseased gallbladder, it will produce symptoms. Sometimes it can cause jaundice, sometimes it causes pain, fever. The doctors can diagnose that by getting appropriate tests, CT scans. They can examine the abdomen, and they can find out if you've got gallbladder disease. Treatment frequently is taking out the gallbladder versus treating it medically. Well, that's all the time that we have for this show. Hope you've enjoyed it as much as I have. Remember, there are 4 things that we think are so important to your health. Number 1 is exercise. The more we look at staying healthy, the more that we know regular exercise is so important. It helps us lose weight. It helps relieve stress. It makes us feel better. There's a runner's high. There's an exercise high. Chemicals that are released from the brain when we exercise. It actually tells us, I want to exercise again. It makes us enjoy exercise. Sometimes I say, I get pretty tired with exercise. But it is of huge health benefit. Getting appropriate sleep. I can't tell you enough how important it is to get 7.5 hours of sleep. Everybody needs a little different. It may be 7 hours or 8 hours, but 7.5 is a good average. If you're not sleeping well, you need to talk to your doctor about why that is. Is it pain that you're having? Is it medications that you're using? Whatever it is, be sure that you're getting sleep. Eat properly. We all know how to do that. And best of all, and most of all, what do we like in the Dr. Bob Show? It's that laughter in your life. Laugh a lot, and you'll stay healthy.